Hi, good morning. My name is Dr. Raymond Douglas, and I'm here with Dr. Jonathan Cabin.
Good morning.
And one of the things that we wanted to talk about on Facebook Live today, and I get questions about this quite a bit, is orbital pain. And, all the patients who suffer with Graves' disease and thyroid eye disease kind of know that orbit pain and pressure, especially the pressure when people describe it, can be so detrimental. I've heard some physicians say that, well, if it's painful, then it's not thyroid eye disease. And frankly, I couldn't disagree more, because that pain is such a part of this disease, as so many people know. And there are two types of pain, one of which we probably won't talk as much about today, and that's the pain of the irritation and the dryness that is constantly bothering people, but blinking and artificial tears helps to relieve. And there's a whole paradigm, and we'll have another Facebook Live event about that, talking about what you can do for that type of pain, or certainly you can find that on our website. We detail that quite a lot. But the other type of pain that I want to talk about today is the orbit pain, what people describe as pain and pressure. And Dr. Cabin is an expert in this pain, in treatment, diagnosis, and really just wonderful that he was able to join us for Facebook Live, because I know that he treats this all day, every day. And Dr. Cabin, so when I encounter a patient with thyroid eye disease, I often ask them, where is the pain? And almost uniformly, patients have a really hard time describing it. Usually they do one thing, they correct me and say it's a pressure, A, and then they say, it's like here, and then they roll their fingers around, and they try to point behind their eyes, but they start at the temple or try to go and point at their brow and kind of go behind their eyes. And this pain pressure that they have is often constant. It never really goes away. Sometimes it'll be relieved a little bit with Advil or something like that. But I've even had patients on narcotics, long-term narcotics, and couldn't get relief, and everyone told them, oh, it's not thyroid eye disease, it's something else. Tell me, in your workup of pain, because you're a pain migraine expert, what does this sound like to you, and what do you do to work this up?
Sure, yeah, and thank you so much for having me on your Facebook. This is great.
Yeah.
The pain that we deal with migraines is slightly different in some ways, but there's a lot of overlap. Usually migraine pain, just to kind of back up and talk a little bit about migraines, is not constant, but it happens intermittently. Some people get them every week, some people get them every month, every year. It's usually a throbbing pain, but some people complain of pressure. The interesting overlap here is that there are patients that come into our office that have the same area of pain, and they'll try to point in the same areas over above the eye and next to the eye, and when you actually start talking about it, you realize that it's actually they're feeling it behind their eyes. And for us in the migraine world, one of the things we have to think about with pain behind the eye is that this is what usually associated with a trigger point for migraines in the nose. It's one of the 4 major triggers for migraines. And so in that sense, it's a similar area, it's a slightly different pain. But the interesting thing is that, I know you've been using Botox and decompression for this kind of pain, and we do the exact same thing in a slightly different way, but it works just as well. So in working these patients up, again, in your world, it's mostly around the eye, and when we're talking about migraines, it can be behind the eye. The other trigger points are on the temple, on the neck, and then in the traps back here. So again, it's a very similar presentation and treatment. It's a slightly different disease.
Okay. And so a lot of our patients will complain, just as I said, about pain in the temple, the pressure.
Yeah.
What's the first steps that patients can take to begin to know whether they can get some relief, either whether it be from Botox or a very tiny little incision that helps with that nerve? What's the first step that patients can take?
So I think the first step in my mind is just getting that diagnosis down. I think if you already have a diagnosis of thyroid eye disease, that's there's a lot of certainty there that that's what's going on. Again, if you have a diagnosis of migraines or you're suspicious for migraines, again, there's certain diagnostic criteria for each one. Then you sort of have your diagnosis and you start there. I think in my world, we want patients to get migraine diagnoses from neurologists. They're the experts in diagnosing migraines. They're the experts in certain migraine treatments. We're the experts in more interventional treatments, which we find to be more effective. But again, the diagnosis is number one. And then once I see a patient, they have that diagnosis, they have that pain, I make them sort of point to the area where the pain is coming from, where they feel it first when the migraine starts to happen. And it usually will be a very, very specific point, that it will be here, not here, millimeters. Once we figure out the certain areas that it's coming from, and again, it's them pointing and also them keeping track of a log over a series of days. Yeah. Then we go forward and we do certain tests in the office, like using a Doppler to find blood vessels, potentially a CAT scan, depending on where the pain's coming from, to figure out what we're dealing with. And finally, we have our trigger points, we have the data to confirm it, and at that point, we make a treatment plan that involves usually Botox, or nerve blocks combined with or surgery, surgical decompression.
Yeah, and I'd say for patients with thyroid eye disease, the real critical thing is that it overlaps with migraine pain and can actually spark migraines. One of the differences and similarities, and we'll talk about those between the two. One of the similarities is that much of the pain pressure can be made worse with sunlight or some triggers in thyroid eye disease. But that pain pressure that most people feel from the orbit is a constant baseline. It can build up toward the end of the day, or it can reach a crescendo or even go into a migraine, but it's always present to some degree, and that's often one of the really tough things for patients to deal with, because they're never truly pain-free. So we'll turn our attention a little bit to treatment. So I became fascinated by the migraine literature many years ago, and especially the treatment of Botox for this disorder and for migraines. And so I thought, well, this pain pressure seems to be very well localized. Patient after patient is coming in saying it's in my temples, behind my eyes, or in the front, in the brow region, a little less commonly. And so I began to think, well, can we use Botox for this? And so we started using Botox and doing a bit of a study to look at the effectiveness of Botox, and found that it's actually amazingly effective. So I was hoping if you could talk a little bit, because one of the questions I always get is, well, is Botox safe? Is it going to cause me to have a funny appearance? All those things aren't true. It is safe and not a funny appearance, but tell me about your experience in those two questions.
Sure. Yeah, that's a really good point, and we get the same questions with migraines. I think Botox is obviously in the media a lot and is talked about a lot from the perspective of patients wanting to look better, cosmetic appearance, and I think that sort of triggers people to think about those things when Botox comes up. What Botox is actually doing is it's relaxing muscle, and that can give you a nice cosmetic appearance in certain areas where you inject it. But where it works for pain is it relaxes muscle around nerves and kind of quote unquote decompresses around that nerve. That's one of the theories of it. And so if you're injecting it into an area where the muscle movement causes wrinkles, yes, you're getting a cosmetic effect. But if you're injecting it into an area that is around a nerve that doesn't necessarily have wrinkles, then you wouldn't necessarily see any change in appearance. You would just have an effect on the nerve compression. In terms of safety, Botox is incredibly safe. It's been used for many, many years. It's used in very high doses in children, actually, who have muscle disorders, much lower doses in adults who want treatment for migraines or cosmetic or thyroid eye disease. And they've never shown anything permanent or life-threatening or anything serious that can happen from Botox. There are some smaller complications that can occur, but on the level of any sort of prescription medication or any treatment. So it's probably the safest thing we do in the office, and I understand why patients get concerned about it based on the media around it, but It's really a very easy and simple treatment. It takes a few minutes. Most people don't complain of pain, and usually there's no side effects.
Yeah. I always say that Botox, unfortunately, was named with toxin in the name of it.
Yeah.
If it had been Bovitamin, I think it would have had a very different reception.
Yeah.
I was speaking to Dr. Bill Binder the other day, who was one of the earliest treaters discovering the use of Botox for migraines and a variety of other things. And he also shared with me that, of new research and other things that have been going on as far as how Botox actually interferes with the neural conduction in addition to the decompressive effect. But the bottom line is Botox is probably safer than an aspirin, and it doesn't, and when the points in which we are using it really don't change the facial appearance in any significant way. So I think that those are two really important points for people to take home and to really understand and to know. Now, the amount of Botox that we use, I know you probably use a little bit more than I do. I use what would be equivalent to 40 units of Botox. So it's certainly not an overwhelming amount. Our studies have shown that it's about 85% effective at relieving the pain pressure for about 2 months. It often doesn't get quite to 3 months, but it's about 2 months. How much pain relief do patients seem to get for migraines and for the other types of pain that you're dealing with in these scenarios?
Sure. Yeah, I will say, to touch on one point before I get into that, we sometimes use a smaller amount of Botox, and a lot of the migraine literature talks about using a very specific amount of Botox. It's about 150, 155 units, which is a lot. That's the way the studies were performed. But once we get into the details and we can kind of really figure out where these trigger points are, we can minimize the amount of Botox we use and really target the areas that the patients need injected and avoid the areas they don't. And then going to your question about pain relief, what we see in our practice is about the same. If the Botox is done to the level the patient needs, they usually get 2 to 3 months of relief. We advise patients to come back in before their migraines go back to the way they were, so that we want to keep on top of this and not wait for it to get worse and then get injected again. So I like to do it about every 2 months. I find that it's a safe way to make sure the patient is always under control. And again, we get effectiveness in the patients that really have the type of migraines that can be treated with Botox. We get over 90% significant relief, if not cure, of the migraine during the period that it's active. So
yeah, and I think that's a good point. I mean, it really is effective if you diagnose it correctly.
Correct. Yes.
Botox doesn't treat dry eyes, so it's not a substitute for artificial tears. But if you have that pain pressure behind the eyes from thyroid eye disease, or if you have a proper type of diagnosis of migraine, it can be extraordinarily effective. How Botox is given is by an injection, which is a scary thing for many people. We put a little bit of numbing cream on the temples and maybe on the brow, and most people don't really feel it too much. What has been your experience when patients, as far as getting this done? Because I know people are fearful. I pass out at needles. So
same here. I can give needles all day, but I cannot take them. Yeah, patients are fearful, and I think there's 2 reasons why. One is just the fact that it's a needle, and needles make people nervous, like myself and you. And I think the other is that the way that Botox is talked about online and certain doctors, neurologists, etc., for migraines is that you need so many injections, and people don't want the 30 plus injections that are involved in the traditional Botox treatment for migraines. Once we talk about the fact that most patients don't need that much, and injections can be actually minimized by going through one point but getting multiple areas through one injection, people understand that this doesn't require as many injections. And I think once they experience this once, they realize that this is not a blood draw needle. This is not a big needle. We use a 32 gauge needle, which I think you guys use in your office. It feels less than a mosquito bite, if that. Patients are surprised at how they feel, how comfortable they feel. A little ice beforehand or numbing cream can completely eliminate any pain. And so the common thing that happens in our office is that patients come in nervous, they get their first treatment, and they're never nervous again because it's not a big deal.
Everyone, especially I know in your office and ours, we really strive to make it not a bad experience, but actually a good experience because a lot of the pain goes away within just a couple of days.
Absolutely.
The other way of treating pain and pressure in thyroid eye disease that we've known for a little bit of a longer period of time has been decompression surgery, and that's worked pretty well. In the customized way in which we've done decompression surgery in our office, we actually take out the nerve. It's a very small nerve that runs inside the orbit, and it doesn't do anything except provide about a nickel-sized area of sensation up in the temple, up in the hairline. And what that does is that dramatically reduces the amount of pain pressure that patients have, and usually on a permanent basis, so it's a one and done. Now, Dr. Cabin is especially trained in doing these types of nerve decompressions all over the head and neck. I do the ones for thyroid eye disease, usually during the course of our decompressions. Tell us, even for patients who might just have pain pressure and don't have anything else, what is an approach? And I know you were telling me an approach of that same nerve, even through a different incision, smaller incision.
Yeah. So that specific nerve, which you get inside the orbit, it's possible to actually, in migraines, when that's considered a trigger, to go in and make a small incision just over the temple here or up here, and many times you'll not only find the nerve, you'll find a vessel that runs right over it. And so you're eliminating that nerve, but you're also eliminating that vessel, which is causing a pounding pressure on that nerve, which triggers migraines. So again, it's a very similar approach, a very similar pathology. The other nerves that we deal with are, above the eyes here, on the temple, as we talked about, on the neck, and then actually there's a very, very unique nerve that we don't actually find the nerve, but we do other things in the nose to eliminate that trigger point. And the whole idea for migraines, which I think is very similar to thyroid eye disease, is that this is a trigger. This is something that's setting off a cascade of events that causes pain, pressure, discomfort. And by eliminating this trigger, this sensory nerve, by either decompressing it or actually cutting it, you're doing nothing in terms of causing the patient any more problems, but you're eliminating that pain.
Yeah.
So.
Yeah, and I think the most important thing is a customized approach.
Exactly.
You don't just start, cutting and injecting. Customized approach, targeted, very small incision, safe, effective, and very minimal pain or things associated with it. So I think, in summarizing the pain, pressure, and thyroid eye disease and the overlap with migraine and how they do overlap probably in many ways, and especially the treatment diagnosis, is really thinking about those basic tenets, understanding the diagnosis, customizing the treatment plan, and doing it in a very minimally invasive way. And I think that's what so many patients get frustrated about in our field, certainly, is having very large multiple surgeries. We try to condense things down. We'll take a couple questions. So one of the questions more about thyroid eye disease is that patient here has taken steroid therapy and it did not work, and then had a drug called Rituxan, which is a type of chemotherapy used for lymphoid malignancies, but also used in rheumatoid arthritis and some autoimmune diseases. And the eyes went down some, but they're still bulging and they swell at times. This is so true. So none of the currently approved medications for thyroid eye disease, including steroids or rituximab, and trust me, I've tried many of them for patients, have ever been shown to reduce the proptosis or the eye bulging beyond what natural history would, meaning just not doing much at all. They'll reduce the swelling and such and maybe improve the short-term consequences. Now, our last Facebook Live, I talked about a new medication, a brand new medication that was just recently published in the New England Journal. We did a lot of the studies. I was the principal investigator of that study of 22 centers, and that's the first medicine called teprotumumab that appears to reverse the eye bulging of Graves' disease. So far, it's only been tried and going to be tried in the next trial, which will be here in Los Angeles, in amongst about 3 other sites. It will it only has been tried in people with early onset disease. We don't know about later stage disease. What I find often in patients who have had this eye bulging, had steroids and rituximab, even a small decompression done through a very minimally invasive way can dramatically improve their symptoms. And decompression has been done for many, many years, and it was never a great surgery. It's finally gotten to the point where when centers and people do enough of them, they can do them through a very minimally invasive approach. And we do a few hundred per year. So we have a very customized, minimally invasive approach. And so often, once that inflammatory phase is over and been treated with steroids or rituximab or nothing at all, we can move to that. In the future, I think teprotumumab will hold some promise. Let's talk about a question from Michelle, who suffered from migraines since she was a child. And I assume that that's very common, of suffering from migraines and pain since being a child.
Yeah, it's interesting. Childhood migraines are a slightly different disease than adult migraines, and a lot of them turn into adult migraines. They respond differently to medications. They present differently. One of the other interesting things is that in children, a lot of times what eventually become migraines is something called vertigo, which is dizziness. And so younger kids, especially those that haven't gone through puberty yet, will get dizzy spells, and those kids, it's called vertigo of childhood, and those kids will eventually get migraines at the same time frame, the same frequency as that dizziness. So that's a very common way for this to start in childhood. But again, migraine pain is also a way that it can start.
Okay.
Yeah.
She had thyroid cancer in 2015 with a full thyroid removal and also parathyroid removes. And left eye has always been lazy, but since surgery it doesn't look good, and above and below, and it seems weaker. Considered low in calcium, and the eye twitches a lot. When she gets her migraine, her vision is extra sensitive, and she's had multiple regular doctor's appointments. But how can we help her, to determine how the migraines, vision is associated, to interfere in that pain cycle that seems to be getting with the migraines?
Yeah, and I just want to say for Michelle that this is an incredibly common phenomenon with migraines, as I'm sure you know. Vision sensitivity, we call it photosensitivity, is one of the biggest things associated with migraines. Actually, any sense, so smell, hearing, touch, a lot of that can be incredibly sensitive during a migraine, and that's why a lot of people classically go into a dark room, they turn off the lights, they put in earplugs. This is something associated with migraines. There's a lot of theories as to why. I think one of the first things in terms of my practice in treating migraines is understanding, where do these start? I'm more interested in not where the pain is when the headache is happening, but where the pain first begins. And so that would be the first thing I would do with you, would be to talk to you about that, have you point to it, and also keep track with a log when these migraines happen, where you're first feeling it. Most patients will feel it first here, behind the eye, on the neck sometimes, or in the temple. There's a few other less common spots. And then once that's isolated, then we can go on to the next test, which is testing it with a Doppler, potentially a CT scan, and finally determining whether you're a candidate for a Botox injection or possibly even surgery. Okay. So it's a little different than if you were to go to a neurologist. It's an interventional approach, and as you were speaking to with thyroid eye disease, the medications can work, but generally speaking, interventions like small injections or a very customized surgery can have a more powerful and longer term effect.
Yeah, there's probably no one single spice, so to speak, that's going to cure everything. But having multiple things, especially some of these interventions that last for a very long time and can give a new baseline, are great. What I often see in patients who've had thyroid eye disease and have vision problems is that their eyes get so dry and they want to squint all the time. So they're using these muscles to squeeze their eyes closed because the disease has caused their eyelids to open up and to retract. So their eyes are dry, painful. They're always trying to protect. They're always squeezing down. Yeah. And that squeezing seems to prompt a lot of their pain and migraines. I'd imagine that's something that you could also help patients with, and to, from both the initiation, which I try to help them with, and as far as dry eye therapy and things, but then also how this prompts migraines.
And I think that's a really good point. And I think one of the things I try to explain to patients is that we like to put things in categories. We like to say, you have this disease or that disease. And when it comes to headaches and pain in general, I think that it's more of a spectrum. There's migraines, there's cluster headaches. Cluster headaches is actually a pretty definitive disease, but there's migraines and tension headaches and sinus headaches. And I think it's a continuum. And some people have a few of those that are all mixed together in what is a unique disease for themselves. And part of what we try to do is have the patient come in and be evaluated as an individual and develop a very customized plan for them. Yeah. What you were saying with squeezing your eyes together, a lot of patients that have migraines, whether it's because the migraines give them stress or give them tension, they'll end up squeezing muscles together as well, and then they get more tension headache-like symptoms, which can also be treated with Botox. So. Yeah. Again, it's paying attention to those little details and making sure that the patient is evaluated as a whole person and not just a disease.
Yeah, and that's why I enjoy working with Dr. Cabin so much, is that I can think of it from the thyroid eye disease component, but he certainly is the migraine expert and can eliminate the migrainous component also. Sure. that can be just so tough for patients to deal with.
Thank you.
So Lisa's had a soft tissue decompression and bilateral decompression surgery and still has eye protrusion, dryness, pain, and there are any options who continue to have post-surgery symptoms. And this is a very common question. I would say if 80% of my consultations have had surgery before, and I think that most of my patients are very happy when we have something else to offer. This type of surgery hasn't been customized and for the eye protrusion in the past, and so everyone kind of got the same surgery, and often that just wasn't enough for some, too much for others, and didn't relieve the pain associated with other things. So we take a stepwise approach. The first is looking at the symptoms. Is it pain from dryness? Are there things that we can do to help with the dry eye, such as closing off the tear drains, which some people may have never even heard of, but it's an in-office 10-second procedure? Are there other things that we can do with the eyelids, or of how far their eyes are sticking out? Those types of things are incredibly critical long before we get to decompression surgery. But then we start to look at their facial morphology. Do they have fat versus muscle type of thyroid eye disease? Is there bone that's still available? Do we want to lower the eye, move the eye back? How best can we provide coverage for the eye? So I can honestly say that really no two surgeries are exactly alike, because no two people are exactly alike as far as their symptoms and what they're trying to achieve and what their goals are. And just because we can offer all these things doesn't mean that someone should have them. Sometimes the risk versus the reward is just too high. But until you start breaking down and at least understanding the categories, and especially whether you have a prominent cheekbone or not a prominent cheekbone, whether you have fat predominant disease or muscle predominant disease, those two variables take our treatment plans in very different directions, and the risk is entirely different. It can go from a chance of having 1% or less of double vision to 15% chance of having double vision. So those types of things are incredibly important. So I'd encourage you, not to give up, because there's often, even small things that can be done to dramatically improve the pain, the protrusion, and of what's going on. 2 is not to have indiscriminate eyelid surgery hoping that gets better. That's the hardest thing to correct. And you know this, Dr. Cabin, when you have facial paralysis or eyelid paralysis, that really limits what we can do. And we're not talking about that, but that's a very hard situation to overcome. So a customized solution, very carefully weigh surgical options before jumping into anything. And decompression is a very different surgery than it was 5 or 10 years ago, because we can do it in such a minimally invasive approach, and it doesn't carry with all these sometimes very tough side effects, including facial paralysis and other things that can cause pain. So just as a primer, we'll have other Facebook Lives that detail that quite a bit more. So on that line, again, we've had patient who's had 5 eye surgeries already, and they're bad again with bulging. Now what? Well, this is kind of a question for me, but so, well, the first thing is that, and again, I can't offer you medical advice without knowing exactly the specifics, but when someone has a reactivation, it's usually due to a couple of factors, and there's a couple things that can be positive as far as the treatment options here. One is that smoking is very, very highly linked with reactivations. So if you smoke in any form, have to stop that, especially while you have active disease going on. Even secondhand smoke, even smokeless tobacco, even vaping, pretty much everything has been associated with, to some degree, with worsening of the eye bulging. The second is that often if it's a true reactivation where you went through an active phase, were okay, and then it reactivated, a lot of times steroids are uniquely effective, much more effective in the reactivation phase than they are in the beginning. I'm actually more inclined to use some steroids, especially IV steroids that have lower side effects in that phase than in the beginning. So it's just one of those things that, you know, it's an option. Rituximab is also an option. Eventually, probably teprotumumab will be a really great option, but that's probably another year or more away from being fully approved to use in all patients outside of our trial, which is, you know, going to be coming up in the next couple of months.
And I will say that even though that was a very specific thyroid eye disease question, smoking has a big role in migraines as well.
That's good.
The data is behind tobacco smoking. There are some patients that get relief from different forms of marijuana, usually strains that they eat and not necessarily smoke, and I don't know the data behind that. But one study I was seeing showed that up to 30% of patients that have migraines have some association with tobacco smoke, whether it's smoking it or being around people that smoke it. So again, probably a slightly different pathology, or physiology, but at the same time, definitely a factor. So
I think that really brings up a couple great points to have you chat about as we, you know, get ready. We're running a little bit over, but to talk about what are things that people can do for diet, environment,
Sure.
or on their own that could potentially improve their symptoms, glasses, sunglasses. What kind of a general advice could you give some patients to try low risk, that just to modify their behavior, to at least learn more about their disease or help their disease?
Sure, that's a great question. I'll start by saying that I think this disease is very personal. It's very individual. And you hear this over and over again from migraine patients, that they feel like they're different from everyone else. And it's somewhat true. Everyone's a little bit different, what their triggers are, what they are exposed to that make them worse or better. And so what I always tell patients first is keep track of your migraines. Do a log, get your own data, and look at it. Because a lot of times when we remember, we say I had a migraine and it was because of light, we actually are specifically remembering one or two things and not everything else. And so maybe it was when you used a certain cleaning product, or maybe when you exercised in a certain way. So once you have that data, then I can say, okay, look at what's going on here. You know, you tended to have more migraines because the days that you did cycling than when you lifted weights, or vice versa. You know, the days when you had stress versus when you were relaxed, which is very common, alcohol, etc. And then we can sort of say, look, these are some very concrete lifestyle changes that you can make. Meditation or yoga, different dietary restrictions. One of the common ones is nitrates, like in aged cheese and wine. And again, it's very personalized. So I think there are some very common ones that a lot of people share, but other than that, it's more about figuring out what works for you. And I commonly help patients, you know, navigate that road in terms of figuring out. I would rather not do Botox or surgery if a patient can get relief and cure from changing their life. And so I'll commonly talk to patients about that. Same thing you were talking about with steroids. You know, obviously we're surgeons, but you know, if patients can get a lot of relief from reactivation with steroids, then why do surgery? We're in it for the patient's best interest. This is not about doing more procedures. It's about getting the patient the best relief. So.
Right. And you know, I'm going to defer the answer for thyroid eye disease just because we're going to do a Facebook Live on diet, on meditation, and some of those alternate therapies, which I think are fantastic and can offer, even if they offer 20, 30, 40% improvement, it's probably better than we have for most of our, many of our treatments. So it's so important, but it's a little bit more complex than today. But we've had several other questions come through, and I'm happy to answer them. You can go to my website, raymonddouglasmd.com, or my Gmail is right on that site, and I'll be happy to answer some of those questions for you. Dr. Cabin, I know that you have a great Migraine Institute website.
Yep, the migraine-associated.com. You can find us if you Google the Migraine Institute, it should pop up.
Yeah.
And we have lots of information on there. There's a blog that we commonly update, and any questions that come through, I'll answer via Facebook or one of the other social media tools that we have. So.
And Dr. Cabin's website, is certainly, we can find it on my website, vice versa.
Yep.
It's really a pleasure for me to work with someone who's so knowledgeable, because I get to learn something all the time. And thank you so much.
Same here. I appreciate working with you, and I hope to have you do a Facebook Live with me one of these days.
Sounds great.
Thanks.
Thank you all.
Thank you.